Good morning, and welcome to the Community Partners Take Action on Social Determinants of Health webinar. This event is being offered as a part of the Iowa State Innovation Model Programming in collaboration between the Iowa Healthcare Collaborative and Iowa Primary Care Association. I'm Bery, the Quality Improvement Advisor for the State Innovation Model with IHC, and I'll be facilitating today. Just a few housekeeping notes before we begin. All attendees will be on mute. If you have any questions or are experiencing any technical difficulties, please reach out to the host who will be moderating via the chat function. I encourage you to send to all for rounded out feedback. Q&A will be following this panel discussion. If you have trouble viewing the recording, click on the Participants button on the upper right of your screen to expand to a full screen mode. This event is being recorded and archived on the Simplify website. Event resources have already been sent out to all registrants. During our time today, we hope to share meaningful actions that can be undertaken to help identify and address social determinants of health at the point of care and across the continuum, including referral processes, partnerships, and using data to demonstrate success. Providing the content and expertise today, we are pleased to have the following panelists. I would like to introduce Yadira Figueroa, Family Support Worker with Primary Health Care. Welcome. And we have Shelby Ridley, Social Worker and Advocacy Program Director with Primary Health Care. Dr. Bery Engebretsen, MD and Chief Medical Officer with Primary Health Care. Charles Hill, Assistant Managing Attorney with Iowa Legal Aid. Welcome. And last but not least, Jennifer Donovan, Staff Attorney with Iowa Legal Aid. I'm going to go through the patient case study and then kick it off to our panelists. This patient came to us as one of our most complex mental health patients. We received records dating back to inpatient mental health stays from 1991 when he was 18. He had already been jailed numerous times and had multiple inpatient hospitalizations. His diagnosis was bipolar affective disorder, antisocial personality traits, and polysubstance abuse. His drugs of choice at the time were ethanol, amphetamines, Valium, and marijuana. He had also made 2 suicidal gestures in the previous 2 months. The patient came to us in October of 2012. He was then 39 years old. He stated he had been in prison 5 times since age 18 and was just recently released. He stated even in prison on medications, he suffered from a seizure disorder he thinks may have been related to crack use. In January of 2013, our provider completed a medical incapacity report indicating his inability to be employed. He also started seeking psychiatric help for his mental health issues and medication management following an inpatient stay and was started on new medications. And this is how his journey began with us. Why is this one of the most difficult of cases? He had a long history of mental illness, starting at about age 6 to 7, 8th to 9th grade education, long history of substance abuse, fragmented family placed in foster care with a high ACEs score, multiple arrests resulting in frequent jail stays and at least 5 prison terms, episodic medical and mental health care, multiple traumatic injuries, some minor, some serious, some self-inflicted, frequently stopped taking his medications, and homeless, typically banned from the Des Moines area shelters. At this point, I would like to kick it off with a clinical perspective, starting with Dr. Bery Engebretsen, MD and Chief Medical Officer at Primary Health Care.
Thank you. I think context is always important, so I want to give you a little background about our organization and sort of as an introduction to the way we approach social determinants. And I think one of our messages really two messages. One is that this is very much a collaborative kind of activity, which, of course, at least the CCCs are very familiar with. And also, it's a sort of long-term activity. It isn't something that you receive a resolution for in a brief period of time. We began as a community health center back in 1981 here in Des Moines. We added healthcare for the homeless funding, which is a special funding stream for FQHCs, in 1989. And that's kind of in the introduction, or the topic, the title, I said, 27-year experience working with community partners and addressing social determinants. And I sort of use that 1989 year as sort of the formal beginning, because with that funding came a mandate to address medical, mental health, and substance abuse, as well as entitlement issues with homeless people. Entitlements meaning disability, housing, Medicaid, insurance, and so forth. And that homeless program funding in 1989 really began to lead us deeply into social determinants as a major issue. Back then, we probably weren't using the term social determinants. That's probably a newer terminology. And honestly, we struggled a lot with a lot of the issues related to social determinants and the issues that we were uncovering. And part of what we hope to do is let you know some of the things that we found successful over the years in making meaningful interventions. So then in about 2005, and actually I say about 2005 because I'm not exactly sure, we were trying to search through the records and find the actual date, but we actually started receiving funding from HUD, which is somewhat unusual and not a normal funding stream, but Housing and Urban Development began to fund us not to provide housing directly, but to connect people to housing and provide what were called generally the wraparound services, which are services needed to keep people in housing. And we've been approached over the years by quite a few agencies, including Social Security, HUD, the City of Des Moines, the Veterans Administration, Social Security Disability, I guess I already mentioned, to help them address some of the issues with our mutual populations of patients and clients. And so one of the things that I wanted to point out is why were we approached by other funding agencies to begin to address these things? It might not usually be considered medical issues. So I think there's really two kind of related issues. One of them which goes back to my, I think, attribution to Woody Allen in one of his movies, 80% of success is just showing up. I actually Googled that and found out there's a lot of controversy about who actually first said that and what was actually said in the beginning. But I like the quote, and I don't really care who made it initially. So by showing up, two things happened. We began to develop both street credibility and also, I guess I would call the professional or institutional credibility. For a couple of examples, in the very beginning of the homeless program, the summer of 1990, our outreach team came up with the idea. It was a very hot summer, and we knew at that time, even though I remember clearly that one of our folks, local folks, said there aren't any homeless people in Des Moines, or there aren't very many. And of course, we knew that that wasn't true. So we actually got a bunch of, literally a truckload of gallon water jugs from Anderson Erickson here in Des Moines, filled them up with water, and the outreach team began delivering them to homeless camps, which, if you think about it, you're camping down by the river, you got lots of water, but you're probably not going to drink it, and you probably don't have easy access to good water. So that, bringing those jugs to the homeless camps actually made a big difference in terms of our relationship. And when somebody from our outreach program appeared along the river, people began to realize that it wasn't somebody there to kick them out, to, cause them trouble, to arrest them. So that sort of established a sort of street cred with us. The other thing that we did was by, showing up at meetings, appearing when homeless issues were being discussed within the community, we were able to then establish sort of a credibility within the professional community of Des Moines. So the best example to me was occurred a few years ago when one of the downtown hotels that actually housed people more basically in an ongoing way as opposed to really being a hotel as we think of it, was slated for urban renewal basically. And we were asked to rehouse the individuals in that hotel to try to keep, obviously all of the sort of societal and political kickback from getting too loud. We were a little bit uncomfortable because we were worried about appearing to be part of the problem, but I think we managed to sidestep that primarily. And we did get all 89 individuals housed, and that's not always a really easy kind of thing because many of the people have convictions. Sometimes they're abuse or sexual abuse convictions, and getting those people housed is not an easy thing. But all 89 folks were able to essentially be rehoused within the allotted period of time. And again, I think that kind of relationships with the larger community brings resources to us. We doing okay with time? Lots of conversation. Okay, so an introduction to the patient, we call him patient A, or we also call him the man with the teardrop tattoo. He has an extensive problem list, as was kind of recited in the very beginning, and very difficult problems. So why did we choose this patient? I think there were a couple of reasons. Because he is complex, it shows us there aren't any quick fixes, and you'll see that there aren't any quick fixes with this particular gentleman. He also illustrates a lot of issues coming out of corrections frequently, mental health issues, behavioral issues, medical issues. It also reminds us that as an organization, we say there's no wrong door. When someone presents to us, we don't really care what the reason for the presentation is. We're going to try and address the problems. And I think personally, for me as a provider, as a clinician, that he's a good case to sort of remind us that everybody's somebody's little boy or little girl at one point in time. This was a child, and now he's an adult, and he's got all kinds of issues. And one of the things, if you listen carefully to that history, I didn't try to actually do an ACEs score for those of you that are familiar with ACEs, but I'm sure his ACEs score was very high. So with that as sort of background and context, if you will, to what we're trying to do as an organization, I'm going to actually at this point ask Shelby to make some comments about how we approach housing from our perspective as a community health center that began primarily as an organization to provide health care.
Sure. So the advocacy department is completely grant funded, and we have grants from the VA, from HUD. We also have a past grant through SAMHSA that helps with substance abuse and mental health. And then most recently, we've been funded through the managed care organizations for some case management and housing as well. And then we have some ongoing community grants. So we have a variety of different case management programs throughout our department. And so oftentimes we can find the appropriate case management program for our clients. We operate under a housing first philosophy, which essentially means that the client doesn't have to be sober, seeking mental health treatment, they don't have to seek any services. There's no such thing as being housing ready for us. And so we're working on housing first, knowing that if you don't know where you're sleeping that night, I can't ask you to be sober or to show up to appointments a lot of the time. So we're constantly working on, okay, what's the housing plan? And if they're ready to work on treatment or anything else, we'll help them do that while they're homeless. So some people really struggle with doing multiple things at one time. Like Dr. E said, we don't provide the housing, but we help them seek housing. We realize that a lot of our clients have multiple barriers, criminal background, evictions, no credit, bad credit, all sorts of different things. And so we really have focused on how do we build relationships with landlords to find that affordable housing for our clients. Most of our clients have very little income. A lot of them are just having SSI, and Des Moines is kind of in a challenging housing market right now. So we're really working on building those relationships with the landlords who will maybe look around some of those challenging backgrounds and willing to give them a chance. And once somebody is housed, we don't just kind of drop off. We make sure that whether or not we're case managing for a little bit to keep them stably housed and making sure they've got those connections to resources. But even if a year down the road we're not, really engaged with services, and then if the landlord calls us back and says, we've got issues, great, let's go back in, let's have a conversation. We've got that relationship and that rapport with the client. So let's see what we can do to keep them housed, and that keeps the landlord happy and continuing to house clients with them. Last year we housed 420 households. That's a mix of single and individual households. The number continues to grow every year. We recently just hired a housing navigator whose sole purpose will really be building those relationships with landlords and being kind of the one person who knows the open units in the community. So we're very excited about that new venture for us. Another part that Dr. Eade talks about that's really important is the community outreach. So my entire team is in the community all the time. We probably spend 80% of our time out of the office, and we're at the shelters 5 days a week. We do camp outreach once a week. We are at the jail 3 times a week. We go to meal sites, and really anywhere that we see clients or meet clients. So anybody at primary health care will often call my phone and say, hey, there's somebody waving cardboard on this street, and if I've got somebody that can go out and do that outreach, we'll go meet them where they're at. That starts the trust-building process from at the very beginning. Try and bring them back in and complete an intake. We use the VI SPDAT, which is the Vulnerability Index Service Prioritization Decision Assistance tool, as our prioritization tool, and essentially the higher the number, the more likely that person is to have a lot of barriers to get into housing. And so we use that for our permanent supportive housing projects that are often HUD funded throughout the community. We're the centralized intake for the community, so we're the hub for all of the homelessness in Polk County. But we really want to meet clients where they're at. So going out to the camps on a regular basis is very important to find unsheltered folks. Client A has been unsheltered for the majority of the last 4 years, meaning that he's oftentimes hard to find, not usually staying in one place for a great deal of time. And so anytime that somebody sees him in the community, they're referring him back to us, kind of as the touchstone place. We've built that trust with him. We're a safe place. So he's consistently coming back to just check in and see how things are going. We met him 4 years ago when he came out of prison. He was literally homeless at that point in time. The person he was working with made the referral to legal aid to work on that SSI case with him. Over the last 4 years, we've helped with clothes, we've helped with food, benefit enrollment, we've done food stamp enrollment multiple times, working on, as he goes in and out of jail, depending on the length of time he's in jail, working with Social Security to get his income back on, which is oftentimes quite a process and often not very fast. So that's kind of a challenge for him to not have that income from month to month. We keep checking in with him for risky behavior. If he needs to see the clinic, we make sure that, we can get him in hopefully that day. We've had times where he'll say, I really need a dental appointment. We've worked out with the dental clinic. If I call, you can find me a same-day appointment, knowing I might not find that guy again. We really work with other community agencies to make sure that he's getting his needs met. We've tried to house him twice. The first time we signed a lease, he stayed one night in the apartment and he wasn't ready. He's telling us he's not ready, and so we'll continue to check back in with them on a consistent basis and say, are you ready? If you are, we'll move forward. each time we get a little bit closer. And so that's really important, that even if we get somebody housed and then they're unhoused in the future, we're going to start back. We're not going to say we're not going to serve you because you failed at housing once. We're going to always start back at the beginning, realizing that safe, decent, and affordable housing is what we really believe in. And so the second time, we're getting closer. You know, he's ready for the unit unit's ready for him. We just kind of have to put all the pieces together. But I think we really believe that we can think outside of the box to meet the client's needs. And so whether that's picking him up so he can get to a medical appointment or really anything to make sure that he's getting the medical care he needs, that he's working towards housing, because he's more likely to show up for his medical appointments and to start working on mental health again if he's housed. So we do a little bit of everything, but we really can't do it without our community partners. And I think, you know, the Social Security process probably would not have been as smooth. We don't have the expertise in that, so, you know, we were able to work with legal aid. We can work with Anawim Housing for his housing needs, and, you know, it's great to have those partnerships in the community.
Shelby, I'm sorry, go ahead, Doctor.
Yeah, was there a question?
No, go ahead.
So the nice segue then to Iowa Legal Aid and the Health Law Project, and I'm going to let Charles.
Thank you, Dr. Engebretsen. I'm an assistant managing attorney with Iowa Legal Aid, and I want to start by telling you a little bit about what legal aid does. There's often a misconception in the community as to what areas we practice in. And so we're a statewide organization that takes funding from Legal Services Corporation, which is an act of Congress that funds us in part. We also work with community partners, as we'll get into a little bit, through grants and state funding as well. With those funding requirements, there's restrictions as to what sort of law we practice. First, we don't do any criminal law. That's often a misconception. People will think that we are the public defender's office. We don't. We don't do court-appointed work for the most part. There's some exceptions to that. We don't do tort litigation. We don't sue people for money. Generally, we certainly never sue other poor people for money. Sometimes we do counterclaims against landlords, and with our partnerships with our community, when that relationship has broken down with the community partner and the landlord, that's really where we come in a medical legal partnership. We have 10 offices throughout the state, and we practice in all 99 counties. We have dozens of attorneys and staff that work for us, but we're centrally located here in Des Moines. So what is a medical legal partnership? Well, medical legal partnership, for those of you that don't know, is a partnership between an entity such as ourselves or a group of private attorneys or a different organization and a medical facility. In this particular case, we have primary health care, although we have medical legal partnerships throughout the state with other primary care association facilities, but also hospitals, public hospitals, and other community health organizations, and also state and county health departments as well. So they're wide-ranging. Specifically want to talk, obviously, about our relationship with primary health care. I began working with primary health care 9 years ago on this project. Prior to that, I believe for 2 years, there was another attorney before I came on that also did that. So we've been having this relationship for over 10 years, and I'm really excited about this particular relationship. And part of what you've heard Dr. Engebretsen and Shelby talk about is their connection to the community. And I think that's really important when we're talking about medical legal partnerships. We have other medical legal partnerships which are very important, but oftentimes those focus on patients that go to a hospital. Here we are talking about helping society's most vulnerable and fragile individuals. And so while we're not only talking about helping them become healthy and get housing, we're also talking about relieving some of the societal concerns that these individuals have, which I think is one of the great parts of a medical legal partnership, is we're not only fixing the legal problems and we're not also fixing the medical problems, but in our conjunction, in our work together, we're fixing the societal problems, the larger upstream issues. And that's where medical legal partnerships, in my mind, need to be, because we treat clinically and legally acute problems. We go out, handle family law issues where someone's a victim of domestic violence, housing issues for wrongful evictions, employment issues for getting unemployment benefits, large range of issues. But when we do that, not only do we fix that acute problem of not getting unemployment, but we're also fixing the problem of what happens once that person loses the unemployment insurance. Right? So then we have a housing issue. Then Shelby's trying to house that individual because they can't make the rent payment. The landlord may lock them out. They may turn to their substance abuse problems that they've had in the past to try to cope with some of those issues. So by stepping in and identifying those legal issues, the medical community and the legal community can work together to address those greater needs. As we all know, healthcare costs keep increasing. There's no ability, in my mind, at least I don't know how, maybe policymakers do, of reducing those costs immediately. So how do we make use of our limited resources? I talked a little bit about how we receive funding. Shelby and Dr. Engebretsen talked about the different organizations to give them money. Those are finite resources. They're not just going to keep giving us money and increase every time we ask. So we have to figure out how we can best serve society with those limited means. And this targeted approach of using medical and legal partnerships targets that specific need and reduce costs overall. I've had a lot of interest from insurance companies, managed care organizations, ACOs, other hospitals as well, addressing some of these upstream issues, because if we're taking care of those needs, then we get rid of that cycle, that spiraling down that I've talked about with these individual cases. I also cherish my relationship with primary health care because I like to think that we're fairly like-minded. And we see, as Shelby talked about, housing first. It's just so critical. You can't have health care if you don't have a home. You can't wound care when you're living in the forest. You can't make appointments. I mean, like Shelby had mentioned, for instance, you can't expect someone to show up. So why set these barriers of saying, if you want housing, I need you to go file 2 job applications, come back, and then we're going to have a team meeting about it, and then we're going to do that. You're setting up hurdles for that individual to fail. And that's what I love about working with primary health care. They focus primarily on the patient, and getting them housed and getting them taken care of, and not worrying about what baggage or problems they bring to the table. I just want to go over briefly some of the types of cases that we handle, that I've handled through medical legal partnerships, and touch on why those are important. I once had a patient who was riding a bus 90 minutes each way to school, and she was catheterized, and she needed to relieve herself by her physician's orders less than every 30 minutes, or had to be capable of emptying that bag every 30 minutes. The school district would refuse to give her a shorter bus route. The individual on the medical side obviously saw the problem, but didn't know how to handle it. I contacted the disability coordinator at the public school system, got that person an individual bus ride, and they were at school within 10 minutes. It was a 1-mile trip that they had her carting all around town for 90 minutes, and she was nonverbal, so she couldn't say, hey, I have to use the bathroom, I have to do this. And she's also prone to seizures. So there's lots of issues that we tackle in those sorts of cases. I also harken back to our relationship with primary health care. When you talk about street cred, I've done a lot of homeless camp evictions as an attorney, a defense of homeless camp evictions. As an attorney, we don't often be able to get out into that sort of population. We serve a low-income population in Iowa legal aid, typically 125% of the federal poverty level and below. But at the same time, there are marginalized individuals in our society that are further removed even from our access. And our relationship with primary health care and their outreach team has been unique and fundamental in reaching that specific vulnerable population. So I just want to thank you for the opportunity after the last 10 years of doing that work. I still have fun going out with Shelby into the camps, and getting my boots on and jeans and stuff. Sometimes I'm in a suit. I've done that before, but so those are some of the cases. I've done cases where I've gotten a father sole legal custody so he could get a transplant for a child when the mother had legal custody but wasn't participating in the transplant team's care plan, and the transplant team refused to do that transplant until I got involved and got sole legal custody for that particular individual so that a transplant could take place. We've done cases where a patient was, his wife terminally ill with cancer, and the insurance company refused to pay about $500,000 worth of insurance claims. We got involved, got the hospital paid. So these are also things that we can do to ensure that the health agencies that we work with are also benefiting from this, not just on a medical patient side of things, which I would agree with primary health care is the most important thing, but also there's a financial component to this of us being involved and being able to recover some of these funds for folks. So I just want to say that medical legal partnerships are a fantastic way of increasing the care that we provide for the patient, but also to better society and the health entities that legal aid partners with in these particular cases. And I'll let Jen talk a little bit about our involvement specifically with patient aid.
Thanks, Charles. So I actually was the attorney who represented client A, or patient A, in his Social Security disability and SSI application. We got the referral from primary health care that he needed assistance with that particular legal issue. And from a legal perspective, it's probably not our most exciting case. It was fairly straightforward. We filed the application. I got medical records gathered, submitted them to Social Security. You've heard the background in terms of his diagnoses, his social history, all of that. He was approved pretty quickly. However, I think it's a really good case in terms of highlighting our partnership with primary health care and kind of the way in which a good medical legal partnership can benefit both the medical partner and the legal partner, and very much, you know, kind of the whole is more than the sum of the parts sort of way benefit that particular patient or client. So one of client A's challenges as far as being homeless was that he didn't have any sort of a consistent way to be contacted. No phone, no steady address, not even necessarily, as Shelby said, staying in the same particular place for more than a few days at a time. So getting a hold of him would have been virtually impossible, except that he did, and I believe still does, receive mail at the primary health care clinic, and he had that relationship with them to be able to check in there periodically, you know, to get his mail, to go in for, you know, when he needed something to check in with his case managers there. And so for us, you know, a lot of our clients being low income, it can be hard for them to keep a phone on. If they move from place to place, it can be hard for them to, you know, remember everywhere that they've got to update their information, and we're not always the top of that list. But having that partnership made it a lot easier for us to keep track of him, to keep in touch with him, and thereby to get the information that we needed to Social Security for him, or to get him in touch with Social Security, or to tell him, okay, he's got, you know, this appointment set up, or he needs to go meet with this person in order to pursue that case. But it really helps facilitate his case and keeping it from just being denied for lack of follow-through, not for any medical, you know, or eligibility qualification reason. You know, another aspect was that because of our partnership, we were able to provide, he was comfortable with us providing more information with primary health care as far as updating them on the status of his case, or with them updating us on how he was doing in other avenues, which helped us gather the information we needed to present to Social Security, and also helped us, you know, kind of coordinate for him, do kind of a warm handoff back to primary health care if he came into our office, you know, talking about another issue, a side issue that he was having. He had that level of trust with them that we could contact them and say, hey, here's what's going on. We're sending him over right now. It's about 3 blocks between our 2 offices. You know, so expect him there in about 10 minutes, and here's what he's got a question about, which I hope allowed them to better serve him, certainly allowed us to better serve him. The other thing is that his relationship to the Social Security Administration is tenuous. Yeah, animosity is the word that's kind of coming into my mind here. I firmly believe there is no way that he would have been able to navigate the system to apply for SSI on his own, to go into the Social Security office to talk with a worker there, to provide the information that was necessary or most relevant to his case, and to pursue that, you know, on his own. And coming out of prison, having no family in the area really, a very scattered family in the area, no stable housing, those sorts of things, you know, it would have been very easy without kind of quick interventions and getting him some income and getting him hooked in with other benefits that he was eligible for and all those things, for him to turn right back around to substance abuse, to criminal activity, to the sorts of things that got him in prison in the first place, and, you know, and for him to just end up right back there. It's my understanding he's had a few jail terms since then, but no major criminal activity, no more prison sentences, no more of the types of activities that he had been involved in before. And so I think really he's an example of what kind of serves that partnership. You know, when there's a strong partnership like that can really have.
And I think about the partnership aspect that I haven't mentioned yet, and I don't know if we've gone into it as much, as clearly our organizations have an organizational relationship. I talked about the relationship that I have with Shelby and her outreach team, but I think one thing I want to make clear is that this is not the outreach or the physician handing the patient off to us and us curing the problem. A lot of times, the work that is done in conjunction with the medical staff. For instance, I had a client who was a victim of human trafficking, and she had an old cat she needed as a therapy animal. A physician wrote a letter for me to be able to make a reasonable accommodation request to keep that cat, work with a veterinarian to say that they were saying you can't have that cat because it's old and it's not declawed, and the vet said you can't declaw the cat because the cat will die during surgery, it's too old. So I worked with medical staff in those kinds of cases. And so reasonable accommodations, in one particular instance, I remember I had a patient who had a young child, asthmatic, and had been hospitalized 10 times. Well, he had 12 ER visits and 6 inpatient hospitalizations in a 6-month period. And we got the physician on board to say what specific type of filter and air purifier would be necessary to keep that child safe and to reduce those levels, and the physician assisted me in doing that. So I think it's really important that we understand that there's a relationship there, that the two professionals are working together to accomplish the task. It's not certainly just not the attorneys doing that, because many times throughout our work, we need the expert opinions of physicians, nurse practitioners, and others to be able to say, this is what this individual needs, so that we can follow up with a legal remedy on our side. So I want to say kudos to all the medical staff that have assisted Iowa Legal Aid with that over the years as well.
So you've heard from a couple, I guess I would say, sort of big picture kind of programs that we're connected with in terms of housing and legal aid. We also do a lot of smaller things. And smaller in the sense that they're usually not grant funded. They come from a variety of sources. And at this point, we're going to turn it to you, to try and kind of outline some of the things she does as what we call a family support worker. I think in some of the new emerging technology, she might also be called a community health worker, which there's been some conversations about, I know, within this realm as well. So,
thank you, Dr. Engebretsen. My title is Family Support Worker, and we have this position in every clinic, and it's a great position because we get, if the patient comes in, we get them connected to different resources. Basically, like the title says, you know, support, we're there to support them. We do the referral to Iowa Legal Aid, we'll fill out the form, and then we send it in. We also have like kind of Dr. Engebretsen said, like smaller services. We have we have some food in the clinic, and it's not like a lot, it's like more emergency food. We provide them with that, and also we provide with a food pantry list. And one big issue that a lot of the clients have also is with transportation. I assist them with them, getting them to places either through their insurance, or we also have cab vouchers. We have tokens. Sometimes also we get a hold of the outreach team, and then they're the ones who can take them to their appointments or like to the Social Security office, different very important appointments that they would have. Also, like if they're coming and they need assistance with applications for food stamps, we do that in the office. If they need assistance with their insurance, we help them with that also. Many of our patients come in and they just get letters they don't really understand, and they just bring them to the office and I can assist them with that. If I have a question, obviously I have a great team that I can ask. And yeah, pretty much anything, like I always say, like my position, if you have a question, just come to me and then I'll find or try to find an answer.
You mentioned something about the smaller things, the clothing closet.
Yes, we also have a clothing closet. Right now with Outreach, they have a bigger closet, but we also have like a smaller clothing closet. We get donations from various groups in the community, people, and also we have hygiene items and like underclothes and socks, especially during the winter. We got donations for hats, gloves, socks, and we like provide that for our patients.
And as you said, a lot of these come from donations. Some of it we fund internally. We have contracts with buses and cabs in Des Moines it costs us less than it would cost if the client had to purchase it themselves. So that's been very helpful, like with specialty referrals and things like that, where people don't have their own transportation. One other program I'd like to mention that is sort of a larger program is the connection between corrections and primary care for people with mental health issues that have been treated with psychiatric medications while in corrections and are now coming out. And the Iowa Prescription Drug Corporation has a formal program in which folks can get up to 3 months of mental health medications for free through the primary care providers. And they are looking for, they've had a little trouble. We've been at it for a few years now, and the data we have shows that the folks that take advantage of this program have a much lower recidivism rate than those that don't. We don't know whether that tells us the whole picture, because a lot of folks don't even show up at all. But if they do show up and if they take advantage of this program, they have fewer follow-up incarcerations. And they're looking for communities to implement this in, and for some reason it's been a little tough going, and they've got money from interesting sources like what do you call it, when the Attorney General gets money from, is that a class action? The Attorney General Office gets like... From a lawsuit? Yeah, from like the drug companies are inappropriately marketing.
Some of those certainly could be class action suits. Tom Miller's office has been pretty aggressive in filing those sorts of claims.
So this particular funding stream came from drug companies that were inappropriately marketing drugs for unapproved uses, and then the money was turned around and put back into mental health medication. So the only other thing I want to mention, I brought up ACEs in relationship to this particular case. He's spent time in foster care, and there were lots of issues with his family. So we have embedded in all of our sites what we call behavioral health consultants. These are, in our case, they're all licensed social workers, and they can address issues related to mental health and human or health behavior by what we call warm handoffs, where we don't have to make an appointment and come back in 2 weeks, but literally on the walkie-talkie I can ask for my BHC, in my case Tony, and she'll come into the room. I'll introduce the patient and her, and then they can begin to work on some of these issues together. We also have substance abuse counselors in our sites from, not that we're doing, but with the local substance abuse agencies. They're employees of those programs to address some of the substance abuse issues. We feel like there's still a lot of things undone. Charles talked about the upstream kinds of causes. I think when you get somebody on disability, when you get somebody housed, you are addressing an upstream problem. But there are the sort of huge upstream problems that these are sort of taking little pieces of, poverty probably being the single biggest driver, but it's intertwined very closely with things like ACEs and racism and so forth that really affect people then downstream. So we need to be more proactive on ACEs, I think. I don't think we do enough within our system to address those kinds of issues. Education for many of our folks is key in terms of finding jobs. Could we work more successfully with community colleges, with ex-offender programs, creating jobs? Fascinating little thing, a young lady in Milwaukee that's creating coat tents, bag coats, is that the name? they're coats that can actually serve as a sleeping bag. She's making those. It's really interesting, and using people that actually can use the devices to help provide them with jobs. And obviously she had to get some external funding to do that. In terms of take-home messages, from my perspective, I will let everyone else kind of chime in. It should be obvious we're talking about building a system. We're not talking about doing all this ourselves. A lot of what you've heard is all to do with connections with other entities within the community. I spent a lot of time sort of thinking about and actually in the larger, broader sort of ecological world or environmental world. And to me, there's always been sort of three cardinal characteristics of healthy systems. And the biggest one is diversity. A cornfield is not particularly healthy. You have to do all kinds of things to support it. And so as you listen here, one of the things you kind of have to give up is control. And you've got to allow a diverse population of agencies and entities, including the patient's clients, participate in the system. Perseverance should be really obvious that, like with this particular patient, we're not done. Highly likely we may never be done. We have a physician in Marshalltown who always talks about, he thinks his main goal is to keep people between the ditches. He's happy if he can keep somebody out of the ditches and sort of keep them generally on they may be in the wrong lane, they may take off down the wrong path, but try to keep them off or out of the ditches. And then finally, healthy systems are regenerative, and so you have to begin to think about, if Shelby leaves, who's going to fix this up? If Charles and Jennifer go on, how are you going to maintain these systems, maintain the connections? And one caveat or cautionary note, I sometimes, Shelby and I were talking about losing sleep, sometimes lose sleep thinking about, you know, is healthcare really the most appropriate place for all of this stuff to come from? You know, do we really want to take all these kind of things on? I mean, and so again, I think that's why, you know, legal stuff, legal aid, housing stuff, the housing authorities, you know, maybe just think carefully about when you take on these problems that you really have the resources. And I'm going to, if any of you have any closing thoughts or...
I would echo that, Dr. Engebretsen. I think that you have to know where your strengths and your roles are as an organization, and I'm just echoing, but you have to identify those people that can do the things that you cannot do and let them do it. You know, for instance, our work with primary health care has allowed me to contact Yadia on a Friday afternoon and say, hey, I got a client that's got a bad wound, it's infected, and this has just happened, and I'm like, I need some drugs because Medicaid's denied it, and I'm not going to get an appeal done at a Friday. You know, I can't get in front of an ALJ or get a decision from the agency in that amount of time, so how am I going to serve that individual? And I reach out to my community partners, and I say, this is something that unfortunately, due to time constraints, I'm going to fail on. How can you help me? And they help me. And that's the kind of relationship that you're wanting to do. And these partnerships, medical legal partnerships, are fantastic, but they're one aspect of what we're talking about, a bigger picture of community connectivity. Okay, so we need to be, Dr. Engebretsen mentioned the re-entry of offenders into our society. We need to be working with our prison systems. We need to be working with our DHS entities throughout the state. We need to be working at our schools. And this is all part of just a web of resources. And when those resources start talking and working together, you can really make fundamental change, because then you're not doing it all. You can rely on your community partners who have the expertise to do that for you, and you can focus on what you're good at. And when they need you, you're there for them, and it's a system.
Well, and I think, you know, kind of building on that, our partnership with primary health care has also led to other partnerships in the community and to our involvement in other aspects. We do outreach at Central Iowa Shelter and Services, the main homeless shelter in Des Moines, and a lot of folks like, well, how is that a medical legal partnership? Well, we do that outreach because primary health care did outreach there, and we started going along, and it's now kind of branched off into its own thing. But we also see the folks from primary health care down there. It adds one more strand in that network. We've, as an organization, had more people involved with committees, you know, in the community as far as housing, as far as other social services, more of the ability to kind of have a voice in some of those arenas, you know, and to be more involved in those areas, which allows us to better serve our clients, and, you know, and allows us to build those partnerships, you know, and expand on them even further, because rarely, you know, when we look at a client with a legal issue, rarely is that the only thing going on, and rarely is that not connected to medical issues or to other, you know, social factors in their life. So it makes sense that if in that one person, there's a lot of different interconnected things going on, that the services that address those also be interconnected.
Very good. Thank you so much, panelists. It's great to hear how you're working together across the continuum of care, and from a broad perspective as well as a more granular one, in your interagency connectedness. We do have a few questions coming in from our registrants. This would be more posed to you, Charles and Jennifer. Are Iowa legal aid services only available in the Des Moines and Central Iowa region?
No. So we practice across the state. We practice in all 99 counties. We have 10 offices kind of strategically located throughout the state. Mason City, Dubuque, Davenport, Iowa City, Ottumwa, Des Moines, Sioux City, Council Bluffs, and did I say Mason City? Cedar Rapids. I missed Eastern Iowa. So we're throughout the state, handling pretty much every type of case other than the ones I mentioned, which were criminal, tort. We do have some limitations into immigration, but can certainly steer you in the right direction on those cases as well.
Great, thank you. To you, Shelby and Yadira, how are your positions funded and supported as a family support worker, Yadira and Shelby as a social worker, and advocate at Primary Health Care?
So all of our positions are supported through grants. So we're the centralized intake that funds 3 case managers who complete intakes all day and complete intakes at the shelter as well. And then through our VA grants, our HUD grants, between the 2 of those fund about 7 positions. And our past grant funds a part of a position. So we kind of, sometimes a full-time position has multiple funding sources and they do multiple programs, but it's completely grant funded, and we lost some grant funding that we had for a long time in May, and so we really went back to the drawing board and said, you know, how do we replace that? We know that we provide a unique service to the community. Sometimes we're case managing folks who others don't want to case manage because they're very challenging and their behavior can sometimes make them ineligible for other programs. And so we know that we're necessary. So we just began our homeless care coordination program that's funded by 2 of the MCOs, and it's kind of a pilot to see if it works, but it's case management, working with the medical side, to hopefully get people into housing, get them stable, and reduce their ER utilization rates. I think it will also probably reduce the amount of times that somebody may go to jail. We've been able to identify some of those high utilizers and can focus on how do we case manage them, get them into housing, and create services. So that's another one of our new programs, and that funds 2 positions currently. So we have probably a total of about 10 grants that fund our positions.
Good, thank you. Sounds like
just to clarify, for the family support workers, it's a little bit different in that it actually began with the Health Care for the Homeless program. That was a position we created to help meet the requirements. And for many years, it was only in the homeless program. It was really only outreach. But over the years, we discovered that there was so much value in that particular position that it actually saved me time as a primary care provider, or the nursing staff time having to do all of these tasks for our patients, that we began to self-fund that several years ago. So we now have that position in all of our sites.
Great, thanks, Dr. Engebretsen, for that clarification. Kind of directed to the full panel, referring to patient A, were you able to see a direct improvement in his clinical care and health outcomes after addressing social determinants of health?
You know, if we wanted to show a success story, we might have chosen another case. I think we just wanted to demonstrate that, but I think we heard there's some indication that he's less in trouble, if you will, than he used to be. He's still very challenging. You know, when he's on his medication, which is, you know, his prescribed medication, not his self-medication, he does better, and that's an ongoing, and we work with this psychiatry program. But, you know, and I don't know, maybe you know some things that I don't know in terms of.
You know, I think the wins are little wins. So he broke a bone jumping over something and went to the hospital, checked out of the hospital after surgery, things like that, but came back to us. So that's a win for us. So then we know, okay, this is a follow-up. We have a good relationship with the hospital. We have a release sign. The hospital could say this is the type of follow-up he needs, and we can make sure that that follow-up happens. So when I found out that he needed these specific medications, I didn't know if he had them. They were super important. I called Lorna at the clinic, and we started kind of brainstorming, like, okay, put the word out. If you see him, call me to make sure that he has that. And he showed up 2 days later and said, you know, I haven't had them. We figure out how to make that work because he can't necessarily always come in and see us. And so if he's down at the shelter, he can see the clinic at the shelter. So we make it work. He comes back in for medical care probably more frequently than he would have. He had not had our connections. You know, we've had some wins with, he had some dental work that really needed to be done. And a lot of that was focused on, it was a day if he comes to us and it's a day he's sober, we're calling, we're figuring it out, we make it happen. So the wins for us in terms of healthcare are when we can get him seen right away because we don't know if he's going to come back the next day for an appointment.
Sure. So celebrating small successes and defining what success is. Thank you. Leading into our next question, how do you all share patient information between your settings as you collaboratively coordinate patient care?
Well, I can touch a little bit on that, or Jen can as well. As we have multiple medical legal partnerships, and typically we receive a release of information. We get patient contact information, then the health entity passes along the contact information to us. We'll sign subsequent releases if we need to get medical records, if it's germane to the representation. We're typically not involved in looking into people's medical records digitally or through their Epic or whatever program that they're currently using. That's not something that we want to get involved in, so we're kind of old school that we get the paper versions of these things, but it's kind of complicated in that we become a business partner and there's a lot more regulation for us and for the health partner if that becomes something that we need to do. So that has been something that we've typically avoided doing.
Well, and the flip side of that, too, is that we're bound by attorney-client privilege on information that our clients share with us is generally confidential. So we do have to get permission from them to release more than very, very general information back to the healthcare partners, which, you know, as in, you know, in patient A's case, you know, his level of trust with primary health care facilitated that because he trusted them, because he had a good relationship with them. He was willing for us to share a little bit more information with them to help coordinate, you know, things with his case and the services that he needed.
And I was just going to add that internally we can share information because we're all one organization, but we mentioned substance abuse and mental health, and we do have formal relationships with those entities. And so if the care, sometimes the care is provided on our site, but if it's provided by the other entity, we need releases. So for some of them, and it's particularly challenging with substance abuse and mental health, we do get actually, in one case, 3-way releases so we can all talk to each other about the issues.
Very good. So beginning the referral process from a clinical standpoint to services outside of the clinic is kind of a dual release issue.
Once it gets to the point where they're actually if they're going to be going formally to like a mental health substance abuse legal partner, if we're going to know we're going to want information, we'll try to do that up front. Sometimes it doesn't happen for one reason or another. We don't even know if the patient's going to show up, so then we have to get it retroactively with or not retroactively, but after the contact has been made, I guess it's a little more challenging because you got to get the patient back somehow to get the release signed.
Sure. How would one go about finding a directory of such needed services like housing or legal support in the local area?
So in Polk County, 211 is always an option, so you can call 211 from any point. I think in Iowa, and it'll direct you to your local one. So we have one here in Polk County. There's a few different resource books, but in terms of housing or homeless issues in Polk County, they're going to refer you to primary health care because we're the centralized intake for the continuum of care. So if you were to have a client or a patient that was experiencing homelessness or was in need of a family shelter or anything like that, and you were in Polk County, they would automatically be referred to primary health care.
Good. Thanks, Shelby. Any recommendations you have as the panel for clinic or community service agency who are in the process and or looking to establish relationships?
Relationships in general, or as to medical legal partnerships, yes, call me. I'd be happy to talk with you. I'm sure that we can share my contact information. Community partners, I'll probably let you address, Shelby.
I think it starts with just understanding what the organization is and what they do, so that you can start by making the best referrals. I continue to learn things about organizations within our community to make those referrals. And then, after I've made those referrals or I've called and asked more clarifying questions, because inevitably I can find a situation that doesn't meet any of their criteria and I've always got to call. You just start building that trust and asking them to kind of step outside the box and, how do we work better together to serve the folks that need it. And I think it's the best partnerships in my mind are the ones that have trust, and I trust that Iowa Legal Aid, once I've made that referral, that they've got it, and they'll tell me what I need to do on my end. But I think it starts with understanding what organizations in your community do.
Sure. So I'm sorry.
Well, I would say sometimes I think the connection actually occurs sort of, if you will, at the street level when people encounter each other, perhaps, dealing with the same patient. And sometimes they occur at the organizational level where the executives of two organizations, one of them thinks, I think like in the beginning, Dennis, called actually the Primary Care Association and said, hey, I have an idea and I think I have some money. So it occurred actually at an organizational level. So I think, it can occur at many levels, but again, it all goes back to knowing what's going on and being in the community and a part of the community and talking to people, going to meetings.
Absolutely. I think going to meetings is what I was going to touch on. Be involved in, our continuum of care board here in Des Moines. It's been a big part of me being able to get out and reach out to other community organizations, but also just going out and meeting with them, meeting with school districts, meeting with DHS, meeting with DCAT funders, meeting with, individuals in your community that serve them. Call them up, ask them for a meeting, and if you're not needing to do that, have one of your employees do that, So I think that just being out there, being aware, because from an attorney standpoint, our position is somewhat changed in the community. I think we've always tried to be a part of it with Iowa Legal Aid, but there has been a larger increase in focus on us being out there and working with other providers and attending meetings and going to the United Way projects that are going on, and the opportunity meetings, and being out there so that we are in the community and get to know these individuals and they get to know us. And then that works back towards what I was talking and what Dr. Engebretsen was talking about, was building that community web and support network out there so that you can make the right connections and refer your patients or your clients to the right organizations and entities.
And I think also being prepared for a partnership not to work out or not to work out exactly how you've been planned. I can think of at least one example where we had a potential medical partner that on paper you look at it and you think this is probably an ideal, of course it makes sense for us to be working together. From a formal perspective, it just never got going. There were some starts and it didn't quite work, and some starts and it didn't quite work. We've had other partnerships where you think, okay, how do these two really go together, and they've blossomed. We've had other ones where, what was maybe envisioned initially is not what it looked like 2 years, 3 years down the road, but it worked out well, it serves the clients, it serves the patients. You know, so just being prepared for those things to not be exactly as you expected, but to potentially still work really well.
And there's going to be the inevitable issues of turf. As soon as you start, you know, looking around, someone's possibly going to begin to feel like there's a turf invasion going on. And actually, there's a very interesting story. I don't even know whether Shelby knows this, but she mentioned centralized intake. But long ago in Polk County, we had, I don't know, we call it homeless helpline or something like that. And some money became available, and someone else wanted to do it. And Shelby's predecessor didn't want to do that, you know, because, well, we've been doing it, we have the expertise, people are using it, you know, why should we let this other entity? And, you know, and I think we talked about it, and my position was, let it go, you know, let them do it. And so they did it for a while, and then, you know, the reality was it didn't work so well, and eventually, you know, it came back to us, and I think now it's better and stronger than it ever was. But you're going to inevitably run into those kinds of issues. You know, and part of that's just the nature of this fragmented healthcare system, health and human services system that we work in. We had to invent a new position, the case manager, a decade or two ago, and now we need case managers to manage the case manager. So because it's so complicated. So you're going to inevitably run into those kind of things, and you're just going to have to work through them on the local community level.
Thank you. We still have some questions coming in from our viewers. What are you tracking in terms of social determinants of health and collaboration between organizations, and are you looking at correlations between the two?
You know, there's a lot of interest in that, and it's very important. I have to say that, I mean, we track homelessness, we track mental health diagnoses. You know, I've always felt that if you put, from the medical side, if you put PTSD and substance abuse together, you've got probably almost by definition a high-risk patient that has a high, and particularly if they're homeless, it's going to have all kinds of needs. Honestly, our focus has been on trying to actually provide services, and, you know, and some may feel that that's not you know, we should, and I think an earlier question was what evidence do you have that this makes a difference? But I think there are lots of people researching these kinds of things in formal sort of ways, from formal, you know, academic institutions, not that they're necessarily the only ones, and we're certainly interested in following that, but many of our stories are much more anecdotal, and I think when you see things happen, when somebody, you know, when 89 people are rehoused, I mean, that is an outcome. You know, we can give you the number. What do we compare it to? I don't know. You know, another city that had a hotel of a similar size. I mean, you know, so I think they're much more anecdotal kinds of outcomes, but I appreciate all the folks that are interested in trying to track those in a more formal way, and, you know, hopefully they would validate what we're doing, or they would redirect us in other directions. I don't know whether you guys have. Yeah. Actually, I'm sorry, and we do have that data that I mentioned about the folks coming out of corrections and the recidivism rate within that population. John has that over at the Iowa Prescription Drug Corporation.
So this has been a huge topic, obviously, on the national level with medical legal partnerships that the National Association of Medical Legal Partnerships has been addressing and focusing on how we can track some of this data. Some of the data that we track, you know, cost savings for the health entity that we are partnering with. We also keep track of instances on more of an anecdotal basis, like Dr. Engebretsen was saying. You know, my example of the individual that had 6 inpatient hospitalizations and 10 ER visits, and then afterwards, in the next 6 months, he had 1. Now, I'm not a statistician, I wish I was, but from a layperson perspective or from our legal perspective, that's kind of the information that we're holding on to at this point until we get a little more, concrete study going on. And it's going to take formal academic studies, correlating a lot of information from different protected sources of, attorney-client privilege, which complicates things in and of themselves to even be able to obtain that data, and then really working through it. So it is certainly something that is being addressed on a national level, and I don't have a great answer for it yet, other than that we keep track of the information best we can, case outcomes. What we do, we track very thoroughly, and so if we obtain someone housing, we keep track of that. If we obtain them a financial benefit, we keep track of that. If we, get them a protective order, we keep track of that. Now, are we following up with the patient 6 months later and saying, have you been assaulted? Not on a grand basis, because it's not something that we do necessarily as attorneys, but we certainly have seen, again, albeit anecdotal situations that are, single isolated instances where we've seen a victim of domestic violence that has been hospitalized, that has had 6 protective orders, and drop them all, and then we get involved through a medical legal partnership, obtain a divorce, get true separation, get a protective order for that individual, and they will go on and become flourishing individuals in society. And we have seen that. Those stories are there. There's lots of reasons, and I'm not a statistician, so I can't say that for certain it was our assistants that did that, but I see it on a day in and day out basis, and for now that's good enough for me.
And I did actually think of another piece of data that we have. 2 years ago, as the regular Medicaid program was closing down, some of you may remember they had the lock-in program for patients that were deemed by Medicaid to be high utilizers of Medicaid services. And at the time that it closed down, there were about 2,000 patients around the state in the lock-in program. And primary health care, for whatever reason, had 10% or 200 of those 2,000 patients. I know that's because we're in Des Moines or what it was, but and on those 200 patients, Medicaid was able to show that we had saved almost $1 million in the period of 1 year on those patients. Now, it wasn't a perfect study because there was no control group, and if you know anything about these kinds of populations and utilizations of resources, there's what's called regression to the mean, which is people that are high utilizers of services don't necessarily always remain high utilizers of services, but some of them will return to regular utilizers of services over a period of time. So we can't say how much of that, because they were compared to themselves the year before and then the year of the study. So you can't, it's not a perfect study, but there was at least some indication that from the Medicaid perspective, dollars were used. How much of that was related to housing, the things that the family support workers do, how would you know? It's, I think that's always the problem, is proving causality.
We touched on provider engagement a little bit, and it making sense that safety net provider like primary health care would have a relationship with Iowa Legal Aid. Any further suggestions for questions coming in about doing this work within larger health systems?
We do. We do with Nebraska Medical. We do with the Blank Children's Hospital, working on a few other ones as well. And so we do work with larger health entities such as Community Point. We have a great program. In fact, Jen's the primary attorney over there. She's housed in Jen Pete's ward, or Jen Pete's clinic, not in the ward, but in the clinic over there, and that's what I did before I took my current position with Iowa Legal Aid for 15 months.
And there's a way to sell this to the hospitals if they don't already have something in place in terms of getting folks onto insurance. When they're admissions, and particularly when they're expensive admissions.
Absolutely. I've never heard any entity come back and say that we've cost them money. The Blank Children's Program is a funded program by them. They've renewed it 3 years running. I don't think that David Stark makes decisions, or not now, Steve Steverson, but makes decisions that are financially, not good for his organization, as he shouldn't. And I think that the evidence that we've shown of what we saved the hospital and procedures that we've been able to obtain approval for indicate the worth of those entities.
Well, and another thing with the larger entities like that, I know that Blank does track some of the data, going back to that component of it. We do provide them with basically the same information that they've already provided to us in the referrals, the names, the patient ID numbers, the basic type of case or issue that was referred to us, and then often just a very basic outcome component of that. Did we represent them? Did we refer them to a private attorney? Did we provide them with some advice on that legal issue? Kind of what did we do? So they're able to then look at that patient to see, did emergency room visits decrease? Is their asthma improving? Now that we got them eligible for, for Medicaid or for some other program, are they able to, get care that they were putting off before? Those types of things.
And in terms of private hospitals or private organizations as well, clinics, everybody's tracked for a customer kind of satisfaction rate, right? Because brand loyalty is hugely important to medical institutions, and I think that we've done really well on that as well. And we've shown that by providing additional resources and services to those patients, that their customer satisfaction quotients go up, and hence the idea that brand loyalty will remain strong.
Excellent feedback. I think that concludes our questions for now, and we are coming close to the close of our recording. So I want to thank our panelists for an excellent presentation. As a reminder to our viewers, this event is being recorded and will be archived on the Simplify website. We encourage you to share this recording and information with your coalition members and your community stakeholders. A post-evaluation will be sent to all of the registrants immediately following the webinar. We appreciate all of your feedback as we continue to develop educational offerings and always look to improve. This concludes our session. Thank you again, panelists, for your time and attention, as well as all our viewers.